Good afternoon, everybody. I would like to thank the organizers for the kind invitation for giving the memorial lecture. It's truly an honor for me. I would like to formally congratulate Dr. Coleman for receiving the Peter Bing Humanitarian Award for Waldenstrom's macroglobulinemia. He received this award last week here in New York City. In the context of having the 10th International Workshop for Waldenstrom's macroglobulinemia. I also will, it's a pleasure and an honor for me to share the stage with Dr. Barrientos here. We do share our Peruvian ancestry. We both are from Peru. If you haven't tried a Peruvian ceviche yet, you're missing out. All right, so down to business. So we're going to be talking today about the advances in the frontline treatments of patients with Waldenstrom's macroglobulinemia. This is, I'm an assistant professor of medicine at Harvard, and this is my email address. I always put it in here. Waldenstrom's is a quirky disease. It affects patients in many different ways. And if you find yourself with a difficult patient, please don't hesitate on sending me an email, and I guarantee a response within 12 hours or less. All right, so these are my disclosures. I don't have any conflicts. I take money from everybody, right? Okay. All right, next. So this is Dr. Waldenstrom's. I used to have this picture of an older picture of him when he was older. I like this picture. He looks young. He looks handsome. So in this picture, in this paper that he published, the seminal paper, 1944, he described two cases of patients who presented with coagulopathy, hyperviscosity, anemia, and in the bone marrow, there was this incipient myelomatosis, as he called it. And it's an amazing thing that 70 years later, we understand the disease so much more that obviously what he did, at least from the biological perspective, I think clinically speaking, he was very astute. And nowadays, we do understand that Waldenstrom's belongs to a lymphoma. It's actually a lymphoplasmacytic lymphoma in which these lymphoplasmacytic cells do secrete a monoclonal IgM paraprotein. Now, with those two first criteria, most of the times we can actually make a reliable diagnosis of Waldenstrom's macroglobulinemia. Having said all that, in the last few years, the WHO and the International Workshop, as well as the National Comprehensive Cancer Network, have added an additional criterion in which the detection of the MYD88 L265P mutation, it has become a hallmark of the disease as well. So if somebody comes to my clinic and they have these three criteria, I think the likelihood that they have Waldenstrom's is very high. And I always quote it as 99.9%, because we're never 100% sure of anything in medicine. This is an interesting concept that I want to just give to you. There is really, if we look at different patients, really there's no relation between the amount of burden of disease in the marrow and the level of IgM paraproteinemia that these patients might have. As you can see here, this actually, each dot is a patient from our clinic, about 600 patients are here. And we plotted at the time of presentations the burden of disease in their marrows as well as the serum IgM levels. And you can see here people with a lot of disease with very little IgM. We have patients with very little disease with a lot of IgM. So I tell my patients, don't go around comparing IgMs, because it's not fair, right? And interestingly enough, many of these criteria, specifically bone marrow involvement, as well as IgM levels, are many times not reasons to treat patients, specifically for this reason, because it doesn't correlate, clinically speaking, very well. Now, in most patients, Waldenstrom's is asymptomatic, and it can remain asymptomatic for a number of years. But in some patients, there is some manifestations of Waldenstrom's. As I was mentioning earlier, it's very heterogeneous, clinically speaking. So the most common reason, if we want to just take all the reasons that I treat patients in my clinic, about anemia is probably 2/3 of the reasons why we treat patients with Waldenstrom's. Having said all that, there are so many other ways in which Waldenstrom's can affect the lives of patients. Hyperviscosity is one of them. We see it in about 10 to 15% of patients with Waldenstrom's. We do have neuropathy, which is essentially the bane of my existence. It's very difficult to treat, and I think you probably will feel the same way. About 1 in 4 patients with Waldenström's would have some type of neuropathy. We also have cold agglutininemia and cryoglobulins, amyloidosis. We have leptomeningeal involvement by Waldenström's called Big Neal syndrome, which interestingly was described before Waldenström described his syndromes. And we have also extramedullary disease. So interestingly enough, I mean, if you think about this, with patients who are anemic, almost never hyperviscous, and patients who are neuropathic, almost never anemic. So it looks like they are different diseases, clinically speaking, but they all meet those 3 criteria, and are having that, and they're labeled as Waldenström's macroglobulinemia. So one of the discoveries we were talking about earlier is the mutation MYD88L655P. This is a mutation that we see in about 95%, at least in our clinic, of patients with Waldenström's. And I think the high level of detection is because we use a lot of techniques that might not be available in the regular laboratory. We select, we do highly specific PCR testing to detect this. Now, about 2% of patients might have a MYD88 mutation, but it's not precisely in L265P, so a PCR testing will not detect this. So this is something to think about. This discovery that came out of the Bing Center for Waldenström's, where I work, has been validated by a number of different studies in different countries. Most recent development has been the identification of mutations in the C-terminal of the CXCR4 gene. There is some data coming up that clinically speaking, these patients might be different, maybe more IgM, maybe more evidence of hyperviscosity, maybe a higher risk of acquired von Willebrand's disease, and maybe some resistance to BTK inhibitors, as we will see a little bit later. Let's talk about frontline treatments. That's what we're here for. So I would like to present different options of therapy, and all these options are very valid. And I would like to start by saying the treatment for patients with Waldenström's is very personalized. There is not one perfect regimen for everybody. And I think that's a very fair statement that I would like to stick in your minds. So we'll talk about the good things and the bad things of all these approaches, and then we'll see how can we make things better. So the combination of bendamustine and rituximab is probably one of the regimens that we use the most in academic centers. And this is based on a very large randomized study with a very small subset of patients with lymphoplasmacytic lymphoma. Each arm was about 20 patients in that subset. And we saw that the response rates were very high, about 80%, with a complete response rate of about 20%. That's pretty decent. And a progression-free survival median of about 69 months. When you can see here the progression-free survival curves, we see a benefit of bendamustine and rituximab over the comparator, in this case was R-CHOP. Now, it is a very potent medication. It works fast. It's reliable. The symptoms, the toxicity is not that bad. Having said all that, there is toxicity. There is some toxicity that we need to talk about. And I think the one that is more concerning for some people is actually this very tiny risk of developing either myelodysplasia or an acute myeloid leukemia. Now, if I think about this, if I have a patient who is, for example, 50 or 60, then I will be more careful about offering a treatment that might potentially cause this type of side effect. So in that sense, there are good things and bad things. The other approach is actually give these patients proteasome inhibitors. And we have 3 in the market. I'm showing you the data on bortezomib, which is the one that has the longest, and with at least 3 or 4 different studies on that. But there is also data on carfilzomib as well as ixazomib, and they all seem to be very effective. Specifically in this study with bortezomib, we combined a proteasome inhibitor with rituximab and steroids. And the overall response rates are very high. In all these 3 combinations with either bortezomib, carfilzomib, or ixazomib, the overall response rate is anywhere between 80 and 90%. So it's very similar to bendamustine and rituximab. And the CR rates, the complete remission rates, are around 10 to 20%, so very decent as well. In the median progression-free survival is actually measured between 5 and 6 years as well. So the benefits of the combination of proteasome inhibitors is very similar to the combination of alkylators with monoclonal antibodies. It works really fast as well. One of the pros on this treatment is that it's not associated with secondary malignancies, right? But bortezomib can give you neuropathy, and we know that by our experience in myeloma. And in Waldenström's, the rates of neuropathy are actually higher when they get exposed to bortezomib. Carfilzomib can potentially give you cardiac issues, as we already know. And ixazomib seems to be more benign, but there is some issues with it as well, specifically with very mild neuropathy. So if I have a patient, for example, who is very interested in not losing sensation on his feet or his hands, then bortezomib might not be the right option, or proteasome inhibitors might not be the right option. There is a risk of zoster with any proteasome inhibitor, and obviously zoster prophylaxis is recommended throughout the treatment on these patients. So as there will be really no clinical trial that will compare these two approaches, we decided to run a study with our own retrospective data from our database. We have about 2,000 patients with Waldenströms in our database. And we put together a number of patients who were treated on the frontline setting, comparing bendamustine versus bortezomib and cyclophosphamide-derived treatments. And we can see here, when we look at the progression-free survival, this is the unadjusted analysis. Maybe bendamustine and rituximab was just a little bit better than bortezomib and cyclophosphamide. And overall survival, bendamustine and bortezomib just a touch better than cyclophosphamide. But in the tables down below, I am showing the adjusted analysis. We adjusted for pretty much anything you would like us to adjust for: age, sex, IgM levels, IPSS-WM, and different factors. And we really were able to prove that either bendamustine rituximab or bortezomib rituximab had better outcomes in terms of PFS and overall survival than cyclophosphamide. So those two tend to be my preferred agents. With that, I'm not saying that cyclophosphamide, dexamethasone, rituximab is not a great agent combination. It works, and there are some scenarios in which we actually recommend this type of treatment. And again, there's a high degree of personalization in this field. Another area of controversy is maintenancerituximab. And I say controversy because there are people like it, some people do not like it. In our database, we ended up treating about 2/3 of the patients with maintenance and 1/3 with observation. And the progression-free survival analysis is on the left and overall survival on the right. We saw some benefits on the addition of maintenancerituximab after induction for both parameters. And this is the non-adjusted analysis. In the tables down below, we have the adjusted hazard ratios. And again, there are benefits statistically significant in favor of maintenancerituximab. Now, this is retrospective data, it's non-randomized, all the caveats associated with that type of analysis. There is a German study, the Maintain study, in which patients received bendamustine and rituximab, and they were randomized to maintenance versus observation. Those results, I hope, will be ready later this year or early next year, and we will have a formal confirmation or not that maintenance might or not be beneficial. So the newcomer is actually Ibrutinib. Ibrutinib is an oral BTK inhibitor. BTK is a very important part of the MYD88 mutation signaling system. And it's a medication that is approved by the FDA specifically for Waldenström's. So we ran this study, 30 patients on the frontline setting. This was recently published in the JCO. And these are our results. We did not include any patient that did not have the MYD88 mutation. We noticed in our initial study that patients without MYD88 mutations do not benefit much from Ibrutinib, and we felt it was not ethical to include patients on this study without that mutation. So all the patients had MYD88 mutation, and again, as I mentioned earlier, a group of these patients did not have CXCR4 mutations, and another group had these CXCR4 mutations, and we kind of stratified the analysis based on that. The overall response rate is 100% throughout, so that's a good thing. But the major response, which is at least 50% decrease on their IgMs, were 90% if you didn't have a CXCR4 mutation, and 70% if you did have a CXCR4 mutation. The degree of deep response, I'm talking about 90% decrease on their IgMs at least, was 30% if you didn't have the CXCR4 mutation versus 7% if you had it. So it looks like CXCR4 mutations, at least for BTK inhibitors, when they're given alone, it might affect adversely the outcomes. The time to response also was affected. 1 month without CXCR4 mutations versus almost 2 months with CXCR4 mutations, and the time to major response, all the way to 50% decrease, about 2 months versus 7 months. Overall, the 18-month progression-free survival was over 90%. So this is an encouraging numbers. The depth of the response can also be seen different here. The blue lines are the patients with CXCR4 mutations, and the yellow ones higher are the patients without CXCR4 mutations. So this, more recently, we had a study combining Ibrutinib and rituximab and comparing against rituximab and placebo. And this included actually some patients who were previously untreated as well. So this is relevant for Frontline. And we saw that the depth of the response was obviously favored in the combination of BTK inhibitor and rituximab. Actually, the depth of the response and how fast that response was achieved was actually much better in the combination as well. And we look at the progression-free survival with a follow-up around 30 months was obviously very encouraging with the combination of Ibrutinib and rituximab. The problem with this study is that this study is telling me that Ibrutinib added to rituximab is really beneficial. But it doesn't tell me that rituximab added to Ibrutinib is beneficial, as there is not a single arm Ibrutinib. So I just put this table here for your observation. I am not making any statistical comparisons, just raw data here. And we can see here when we look at untreated patients comparing Ibrutinib rituximab versus Ibrutinib Frontline, the overall response rates, major response rate, very good partial response, seems to be very similar. The follow-up is shorter on the Ibrutinib Frontline, but at 18 months it's around 92% versus 30 months, 82% with the combination. So I think both options are reasonable. I'm not advocating in favor of one or the other. I don't think there's any clear benefit over one versus the other. But there are two options that we need to have in mind when we counsel our patients. Again, Ibrutinib is not the solution, the answer to all our prayers. It does have toxicity that some people might not find appealing, specifically the arrhythmia issue. Here is in the 5%, but it's actually a little larger than that. Our experience is anywhere between 5 and 10% with atrial fibrillation. There is also the issue of bleeding because it affects the platelet aggregation, and the fact that you have to be as a patient, you have to be taking this medication indefinitely all the way to progression or unacceptable toxicity. So that might not be too appealing to some patients too. So I'm going to just mention this relapse refractory study in preparation for the next couple of slides. Venetoclax, and you have heard about Venetoclax earlier today in CLL. So we did also study, phase 2 study on patients with relapse refractory Waldenström's. The dose is very different. Patients with Waldenström's, these Waldenström cells might be a bit more resistant to Venetoclax than CLL, that those cells tend to be more sensitive to it. So this is actually a study in which 4 centers participated. Our center, Cornell here, participated with us as well, City of Hope, and Stanford. So we put together around 30 patients, and we started at 200 milligrams, which is actually high for CLL, went up to 400, ended up with about 800 milligrams. That was the way we designed this study. And we continued therapy for about 2 years, as long as the patients did not have any progression or unacceptable toxicity. This is just quickly the results of this study. Each bar is a patient, and the length of the bar correlates with how low the IgMs went. So we see here that over 80% of patients had at least a 25% decrease on their IgMs. We have that 70% have at least a 50% decrease on their IgMs. And we see that about 20% of patients had a very deep response approaching the 90% decrease on their IgMs. And this is with a follow-up of just 12 months. The blue ones are patients who were not previously exposed to BTK inhibitors, and the yellow columns are the ones who were previously exposed. So we see that despite the prior exposure, patients do have response to these treatments. What got me the most excited about this data, so I know it's effective. I mean, we know it was effective. But what we are seeing here is this graph on the right, is the burden of disease in the marrow. We're actually seeing that burden of disease decreasing greatly over the first 6 months and sustained all the way to cycle number 12, at least in the patients who have had this parameter measured. So not only we're affecting the IgM, decreasing the spleen size and the lymph node size and improving the blood counts, but we're also cleaning up the marrow. So maybe we are not too far off thinking that Venetoclax therapy could potentially be stopped at some point in patients with Waldenström's. And based on that, this is the next clinical trial that we have planned at the Dana-Farber Cancer Institute and the Waldenström Center. And this probably will be a multi-center study as well. We are going to combine Venetoclax 400 milligrams once a day and Ibrutinib 420 milligrams once a day, but we will continue therapy for 2 years, and then both therapies will be stopped, and then we will watch these patients. The idea being, can we use the BTK inhibition in concurrent with the BCL2 inhibition to clear the marrow, to get patients into deep responses, and then stop therapy. So these therapies are not indefinite. So that's what's coming, and I think we will activate this study probably early next year. So to conclude, and I'm on time, that's the first one. Alkylators, proteasome inhibitors, and BTK inhibitors, with and without rituximab, now are clearly standard frontline treatments for patients with Waldenström's. The choice of therapy, and I hope you go home with this message, is largely personalized. There's not one perfect regimen for each patient. Now, future studies, at least from my opinion, should focus on deeper, longer responses, but with finite treatments. And if we can do that, I think we will advance the field greatly. And with that, I really want to thank you for your attention.